Hi, my name is Claudia Vukovich, and I'm the coordinator for the asthma program here at UC Davis. And we're going to talk today about different respiratory medication delivery devices, also some mucus clearance devices, and some devices for helping nasal sprays and such. So the first thing I want to talk about is inhaled devices, inhaled medication devices. There are two basic kinds. There's the MDI, and then there's the DPI. Now, within the DPI, or dry powder inhaler, MDI is metered dose inhaler, there are lots of different kinds of devices for the delivery of dry powder. But the first thing I want to talk about, we'll talk about that later. The first thing I want to talk about is how to deliver metered dose inhaler. So, one of the important things to remember when you're teaching a patient how to use a metered dose inhaler is for them to use a spacer. If they come into the hospital and are placed on respiratory treatments, make sure that you tell them to take their spacer home, one that you give to them. Make sure you tell them to take it home because they're hard to come by outside of the hospital. And if they are able to come across one, to purchase one, they're pretty expensive, and I don't believe they're covered by insurance. So, a lot of times what happens with metered dose inhalers or any medication delivered, respiratory medication, is that the doctor hands the patient an inhaler and says, hey, take 2 puffs of this 4 times a day. But they don't give them any instruction with it. So, when you're instructing a patient, what you want them to do is shake the device first, put it in the end of the aero chamber, and shake the device. The reason you use an aero chamber, obviously, is because, and show this to the patient, that when the medication comes out of the inhaler, the cloud is way out here. See that? So it comes out at about 60 miles an hour. If the patient puts this directly into their mouth to inhale, most of the medication is swallowed. It impacts the back of their throat, and they swallow the lion's share of the medication. That's why they use an aero chamber. So you just want to mix the propellant and the medication together. Exhale, put the mouthpiece in their mouth, between their teeth, and close their lips. Actuate the inhaler 1 time. Make sure you're clear with the patient that you tell them 2 puffs is not boop, boop, and inhale. It's 1 puff per breath always. Make sure you're clear with them about that. And 1 puff, actuate, inhale, slowly and deeply, but not so deeply that it makes them cough. And always make sure you tell them to hold their breath. 1, 2, 3, 4, 5, 6, 7, 8, and exhale. Tell them the reason that they have to hold their breath is that so the particles will stick on the airways. Otherwise, they inhale the particles and then they'll blow them right back out again. Tell them to wait for 30 seconds or so. Shake, exhale, mouthpiece in the mouth, actuate 1 time, inhale slowly and deeply. Hold their breath for a count of 8. Always show them what a count of 8 is. And tell them that this thing whistles when they inhale, that they're breathing in too quickly, and that they should slow their inhalation down. If they don't have an aero chamber, a couple things will work. People have used the inside of a roll of toilet paper, that little cardboard roll that's inside a toilet paper roll. Another thing, if they have nothing to use, and this work is just as effective as using an aero chamber if it's done correctly. 4 fingers out, below the nose, and exhale. Open their mouth, exhale. Open their mouth, begin inhalation, actuate 1 time, continue inhalation, and hold the breath. Otherwise, it's just, if they do this correctly, it's just as effective as using an aero chamber. The next thing we want to talk about is dry powder inhalers. There are lots of different dry powder inhalers. The way that they're taken is slightly different, and then it's a fast inhalation. The first one that we're going to talk about is the Discus. The Discus was almost the first dry powder inhaler to come out. new generation. It's available as Advair if it's purple, or if it's green, it's Combivent, which is the long-acting beta agonist on its own. The way to take this is to use the thumb notch and push this till it clicks back into place, which exposes the mouthpiece. From then, they push the trigger back, and it will click, and that means the dose is loaded and ready for the patient to breathe in. Have them always hold it horizontally, not up and down, because the medication will spill out of the device and they won't be getting it. Have them turn their face away and exhale, because you don't want them blowing into the device. Mouthpiece in the mouth between the teeth and close their lips. Inhale briskly and deeply, but not so deeply that it makes them cough, and always do that 8-second breath hold. Now, with these devices, there is a counter on the front of them. The last 5 doses will be in red to warn the patient that there are only 5 doses left. So the counter tells us how many doses are left on the device, not how many doses have already been taken. If the patient is using the Advair Diskus, that's a combination medication that has an inhaled steroid and a long-acting beta agonist in it. As with any inhaled steroid, patients should always rinse, gargle, and spit when they finish dosing themselves. Now, I want to talk a little bit about the Advair. Advair Diskus, as well as Advair comes as a discus and as a metered dose inhaler. Now, there's a difference in the dosing. With this stuff, with the discus, the dosing is 1 puff BID. With the metered dose inhaler, the dosing is 2 puffs BID. If you want the patient to get more steroid, you never have them increase to more than 1 puff BID. You go up on the strength of the Advair. It comes in, as I say, it comes in 3 strengths. The reason for this being that if you have them take more than 1 puff of this, they're doubling up on the long-acting beta agonist, the salmeterol that's in it, which can have some cardiac side effects. So the discus comes in 3 strengths. The Advair Diskus comes in 3 strengths. 150, which is the low dose range. It's green on the inside. Medium dose, which is 250/50. The first number denotes the micrograms, the dosing of the fluticasone that's in it. The second number, the number of micrograms of salmeterol or Combivent, long-acting beta agonist that's in it. So 250/50 is the medium dose. And the high dose is 550. So green, yellow, and then red for the high dose. Again, always have them rinse, gargle, and spit when they're finished. Now, the metered dose inhaler for the Advair comes in low, medium, and high range. And the low dose is 45/21. The medium dose is 115/21, and the high range dose is 230/21. This can be used with a spacer. If patients are using an albuterol and an Advair MDI or Gelareh or Symbicort, we'll talk about that in a minute, they can use the same spacer. There's no reason for them not to be able to use the same spacer for all of their medications that require a narrow chamber. The other medications, the other metered dose inhalers that are available for maintenance medication for asthma or for COPD, combination medications, is Symbicort and Gelareh. Symbicort is budesonide. It comes in 2 strengths, 80/4.5, and it's a combination of budesonide and formoterol, which is a long-acting beta agonist. The biggest difference between Combivent or salmeterol and Foradil or formoterol is onset of action. Formoterol has a much faster onset of action, which is the same as albuterol. So, probably they should feel it within 30 seconds. Patients tend to be more compliant with medications that they can feel working. So sometimes Symbicort or Gelareh is a better way to go, because Gelareh also has formoterol in it. The steroid that's in it is mometasone. So the 3 combination maintenance medications that you can use here are Advair, which is available as a Discus and as an MDI, Symbicort, which is available only as an MDI. It also has a counter on the top which tells you how many doses you have left. It comes in 2 strengths. The Gelareh, which is also a meter dose inhaler, it has a counter on it. This is an old, there is a counter on the back of it here. And it comes in 2 strengths, 100 4.5 and, 100.5 and 200.5. So they call it a low and a high dose. These are to be used with a meter dose inhaler. As always with any inhaled steroid, always rinse, gargle, and spit after.
Just one question for you. Usually we hear that to prime the MDI. What do they mean by priming and how often it should be done?
Okay, so priming needs to be done with meter dose inhalers when you first take them out of the package. You don't need to do, if you haven't used it in a while, like if you have rare albuterol use or something, yeah, you need to prime it. But other than that, out of the box, you're supposed to waste 2 doses of the Symbicort or the Gelareh as soon as you take it out of the box. But they do not need to be primed in between uses if you're taking them once a day or BID.
And second question is, you mentioned that when you give steroids, that they have to gargle and spit it out. Why would they do that?
Okay, so steroids change the natural flora of the mouth. It alters the natural flora of the mouth so that a patient can develop candidiasis or thrush in the mouth. And so you rinse, gargle, and spit with water. You don't want them to use a mouthwash, anything alcohol-based. You want them to use water because the steroid itself can cause some soreness in the mouth, and you don't want to exacerbate that by using something alcohol-based. So rinse, gargle, and spit with water.
Thank you.
Now, before I go on and talk about the other meter dose, dry powder inhalers, I want to talk about when to use a nebulizer. If a patient is too short of breath to hold their breath when they're taking a breathing treatment or when they're using any respiratory medications, then they should use a nebulizer. If they're too short of breath to hold their breath, they should use a nebulizer. That's not the only reason. Another reason you would use a nebulizer is if there's some medication that cannot be delivered by meter dose inhaler, like tobramycin, Toby. Now, you're saying, well, how can we give these patients, combination maintenance medication? There are some medications out there, long-acting beta agonists and inhaled steroids that are available as in nebulized formulation, and those are Bravana, and Pulmicort Respules, and there is one other long-acting beta agonist that's available in nebulized form. I can't think of the name off the top of my head. But so you can deliver these combination LABAs and inhaled steroids by nebulizer. Now, believe it or not, there are right ways and wrong ways to use a nebulizer. How many times have you gone into a patient's room and seen this? So anyway, I told him, if you think for 1 minute that I'm gonna be, well, you're gonna, this is what you see. This is not the right way to take a nebulizer treatment. Make sure you tell people when they're using their nebulizer, when they inhale, no smoke should be coming out of the pipe. When they inhale, there should be no smoke coming out of the end of the pipe. Instruct them to inhale as deeply as possible, hold 1, 2, and exhale. Pretty simple. Tell them to put their cell phone away when they're talking. Tell them this is a treatment just like this is a treatment, just like an insulin shot is a treatment. And there are right ways to take it and wrong ways to take it. When the nebulizer begins to sputter, the treatment is over. None of this business. Don't do this. Don't do this. Don't knock it down. For one thing, you're not getting enough bang for your buck to make it worth your while. The second reason is when people are taking their treatments correctly and inhaling and exhaling through the nebulizer, they salivate. The saliva can drip down into the nebulizer cup and be nebulized, and you're inhaling all of the bacteria from the mouth into their lungs. So, I mean, it's not a big deal. As I say, you don't get a lot of bang for the buck when you start doing that tapping stuff. Just when it starts to sputter, you're done. And that's when else do you use a nebulizer? 3 reasons. Too short a breath to hold your breath and take a meter dose inhaler or dry powder inhaler correctly. If you can't deliver a medication using the inhaling devices. And the third reason is if it makes the patient feel better. There's no reason not to give them a nebulizer treatment or pull them away for home use, particularly people with COPD. They have a lot of fear, they have a lot of anxiety or not being able to breathe. If a nebulizer makes them feel better, let them use it. No reason not to. Okay, so let's talk about some other dry powder inhalers. The next one I want to talk about is the Asthma Twisthailer. This is mometasone, it's an inhaled steroid. The way this works is that you twist the cap off, you'll hear a clicking noise. There's a counter, the counter will go down, that means the dose is loaded and ready for the patient to breathe in. Take the cap off, instruct them to hold it horizontally, turn their face away and exhale, mouthpiece in the mouth, between their teeth, and close their lips. Inhale briskly and deeply, and hold the breath for a count of 8. One thing to remember with this device is that there are vents on the side. Make sure they don't put this thing so deeply into their mouth that they can't pull air in during inhalation. They have to be able to entrain room air, or they're not going to be, or entrain air, or they're not going to be able to get the dose. Again, this is an inhaled steroid, so they want to make sure that you want to make sure to instruct them to rinse, gargle, and spit after. This is not on our formulary. We don't use it. It's the Flexhaler. It's an inhaled steroid, and it sounds like a duck call when there's a little. It's a pulmicort budesonide. There's a little twister on this bottom, and you twist it one way, twist it the other way, and you hear a click. Again, from there, it's after you do the first little fancy stuff at the very beginning. It's basically all the same. So have them turn their head away and exhale, mouthpiece in the mouth, and inhale quickly. And deeply, it sounds like a duck call. Again, inhaled steroid, make sure they rinse, gargle, and spit. The next inhaler that I want to talk about is the formoterol aerolizer. This is a pill. Well, this is not a pill, this is actually what some people say looks like a crack pipe. But this is the little inhalation device. There's a pill. The pill goes inside. There's a little impression in here. And the pill goes inside like this. Have them close the pipe up like this. And then there are these little triggers here. Have them push this in. You'll hear a click. That means the pill is pierced and the powder inside is ready for the patient to breathe in. Have them turn their face away and exhale, mouthpiece in the mouth, breathe in quickly and deeply, and have them hold their breath for a count of 8. You'll hear when inhalation is fast enough, you hear a little spinning noise. That means the pill is being jangled around inside so that all aspects of it can reach the hole in order for the powder to be inhaled. This is Foradil, a long-acting beta agonist, to be taken twice a day. The next thing I want to talk about is the Spiriva Handihaler. This stuff is great. I love this stuff. This is tiotropium. It's a long-acting anticholinergic medication for the use for COPD maintenance. And this stuff is great. Why? Because before all we had to offer our patients was an Atrovent inhaler, 2 puffs to be taken QID. Compliance was not great. It's a short-acting anticholinergic. Anticholinergic medications are a first-line drug in the maintenance of COPD. And quite frankly, we use it with asthma maintenance as well for difficult to control patients. So the way this stuff works is, again, it's got a pill. You have them open up both sides of the device, and again, there's a pill, there's an impression inside here. The pill goes inside. There's a little filter on this side in case any spill, anyway, there's a filter inside, a screen in here, I should say. close down just the white part, it will click into place. Have them push the trigger in. There's a little window there. They can see that the blades are being pierced with a little blade, a couple of little blades. If there are clicking noise, that means the pill has been pierced and is ready to breathe in. Always turn the face away from the device and exhale, mouthpiece in the mouth between their teeth, and inhale quickly and deeply, and have them hold their breath for a count of 8. This is one pill, 18 micrograms, once a day, and it works very well. The next thing I want to talk about is the Combivent. Where's my Combivent? Is there a rescue man over there? Okay, so we found the device. Woohoo! This is the Combivent Respimat. Combivent is a maintenance medication. Combivent is a combination of albuterol, the rescue medication that we use all the time, and Atrovent or ipratropium. And this used to be available as a meter dose inhaler. This is not a Combivent. Anyway, it used to be available up until July as a meter dose inhaler, but they went to this formulation of a Respimat. So it has no propellant in it. You do not use this with a spacer. This passively doses the patient as long as, so what they do with this thing, let me show you, is take the cap off. There is a counter on it, over here on the side. I don't know if you can see that or not, but there's a counter here that tells you how many doses you have left. Okay? Again, this is a maintenance medication, typically used for COPD patients, and dosing is 1 puff QID. 1 puff QID. It's not a meter dose inhaler per se, but it is a wet inhaler. There are wet particles inside. The way this is dosed is you have the patient turn the device clockwise, a 180-degree turn, and you'll hear a click. That means the dose is loaded and ready for the patient to breathe in. There's a trigger here on the side, this gray button. The way they take this is to push this button. The medication is dispensed in a really gentle flow out of this, out of the mouthpiece here, over 1.5 seconds. So the patients don't have to inhale quickly, they don't have to inhale slowly. It's just pretty much a normal inhalation, deep, hold their breath. And you'll see when this comes out, it's a really gentle cloud. See that? And it's dispensed, as I say, over 1.5 seconds. They put the mouthpiece on this, they inhale. As they push the trigger, inhale at the same time. Okay? And that's the Combivent Respimat. Some people it just replaces Combivent. The trouble with this is that it's so expensive. This, one of our patients told us that he was on the hook for $300 a month for this stuff. People can't afford that, especially people, COPD patients on a fixed income, they're older. This is a great drug, but it just hasn't really, the insurance companies don't have to pay for it yet, so they don't. One thing that I wanted to go back and talk about was
Advair, hoarseness.
Right. Okay, so what we're having a lot, now that we have choices, we don't have to give Advair to patients. Now we have Symbicort and Gelareh to use instead if we choose. Many people are complaining of hoarseness with the Advair. There are 2 reasons for this. One is that the dry powder in the discus can cause the hoarseness. There could be something in the formulation that people are complaining makes them hoarse and gives them a sore throat. The other thing is that the inhaled steroid, the fluticasone, tends to be more irritating than the steroids budesonide and methimazole that are in the other, the Symbicort and the Gelareh. So you can either take the patient off the Advair Diskus and switch them to the Advair MDI, but they're still going to have the fluticasone in, which can cause them to be hoarse. Or you can just switch them to Symbicort or Gelareh, and I don't want to say it eliminates the problem, because people can always have hoarseness with any inhaled steroids. With any inhaled anything, they can have hoarseness or sore throat. But this will mitigate or minimize the problems with hoarseness. We don't have nearly as many people complain of sore throat with these medications. The next thing that I want to talk about is the Tudorza. Now, Tudorza is another long-acting anticholinergic but it doses at BID. And it's 1 puff. This is called a press air. It's a dry powder inhaler. And there's a counter here on the front that will tell you the number of doses you have left. Counters always tell you how many doses you have left. With the Tudorza press air, you have them take the mouthpiece off. They push this button down. Make sure you have them, when they push the button down, they shouldn't breathe off of it until the button is then back in its original position. So they push it down to lower the dose and let it up. Now that turns this little panel here green. When that means the dose is loaded and ready for them to breathe in. They put the mouthpiece in their mouth, exhale first. Mouthpiece in the mouth and inhale quickly and deeply. Now this is breath actuated, so you have to make sure that, or the patients have to make sure that they inhale fast enough so that it will open the channel to allow the medication to be dispensed. That will turn this little green window to red. So it works like this. You inhale, and see the panel is turned to red. You heard a clicking noise. That means that the channel was opened, or the little door was open, and the medication was allowed to be dispensed. And as always, you want to do a breath hold. This is an anticholinergic medication. People do not have to rinse their mouth out after either the Tudorza or the hand inhaler. It's not going to hurt them to rinse their mouth out. They don't have to. Inhaled steroids are the only thing that actually require people to rinse their mouth out. One thing you want, when they're dispensing of the Spiriva pill, tell them not to put it on their hands and then rub their eyes. It can cause a little bit of blurriness. Just something to bear in mind. It doesn't happen very often. And that's what I wanted to talk about in the inhaled devices. But then I also wanted to talk about one thing for asthmatic patients. Flow. When people do peak flow, make sure you don't have them do an FEC maneuver. You don't want to send them into fits and bronchospasm. Peak flow is a simple maneuver. It's just big breath in and blast the air out quickly. It's how fast the patient breathes at the peak of exhalation. This is a peak flow maneuver. That's a peak flow maneuver. They're not doing spirometry. They're checking their peak flow only. There are cheats with the peak flow meter. They can tongue it, which will give you a falsely high reading, or they can cough into it. Any sort of, while solving any sort of back pressure that's created will cause that needle to jump up and give you an erroneous reading. I'm sorry to go back here, but I wanted to talk to you about what do you do with a patient who, say, has had a CDA and you still want them to get MDIs. Their mentation is fine, they just can't get a good mouth seal. So they make these devices, which is an aero chamber with a mask on it. And so it makes it perfectly fine for someone who doesn't have the muscular strength to get a good mouth seal around the mouthpiece. It's just given this way. This is also available in pediatric sizes and works very well for kids. Obviously, you can't get a 2-year-old to do this, without help. So you use one of these things. Okay, and you can use on little babies. Look at that, isn't that crazy? All right. So with I want to talk a little bit about nasal drugs and nasal treatments. People who have rhinosinusitis, nasal congestion due to allergies, because they wear a cannula and it dries them out, whatever have you. There are so many reasons for nasal congestion. The best thing that a person can use for nasal congestion is this. We use it all the time in clinic. For about 85% of the patients who come to us with an allergic asthma also have an accompanying allergic rhinitis. So the way this stuff is used is it comes in all different brands. This happens to be Neomed Sinus Roots. This was the original. It's used it's a saline solution that the patients make themselves. They use a salt packet. Make sure they use the salt packets that are approved for use with nasal irrigation, not table salt. This is a buffered salt, does not have iodine in it, and it's cleaner. So, salt packets, not water. Water itself, water without salt in it, just water it can cause nasal irritation, sinus irritation. Put the salt packet in, fill to the dotted line in order to get the solution right. They're not saving any money by using they have to get the solution right. Have them use not tap water, have them use distilled water. Why? Because the tap water has all kinds of bacteria in it that you don't want people to put up their nose. They'll get nasty sinus infections from that. So, the way to take this is to have the patient lean over the sink, put the nozzle up to their nose, and squeeze the bottle till the water either comes out of their mouth or out of the other side of their nose. Make sure they do the other side as well. This does several things. It helps to clear the mucus out of the nose so they can breathe. It helps to reduce the swelling of the sinus tissue, and it provides since the mucus is gone, it provides a slick surface so that irritants won't readily stick to the sinus tissue. When they're finished with the dose, throw the rest of it away. Don't reuse the bottles because it's gross. Don't reuse the water, the saline solution. And one more thing to remember: if a patient has a blockage, if they're so congested that they can't readily, easily push the saline solution up into their nose, don't soldier through because they can rupture their eardrum. I know it's common sense, but I've got to tell you. Now, the next thing that's not quite as forceful is the neti pot. I want to meet the guy who looked at a teapot and decided that would be a good thing to put up his nose, but whatever, it works. It's the same premise, it's the same brand actually. Saline solution, salt packet, distilled water, and it just uses gravity. So the nose piece goes up to the nostril, and they just turn their head and tip. And it just uses gravity. It's a little more gentle than forcing this stuff through. Something new that is being used for people who have chronic rhinosinusitis, difficult to control, is that inhaled steroids, Pulmicort, budesonide, Respules are being put into this solution as well to help reduce the sinus swelling. That's being done by ENT and also by allergy, and actually we've done it with a couple of our patients in clinic. Nasal sprays. People complain all the time. I don't use my nasal sprays because it hurts. It causes sores on me. Okay, well, again, there are right ways and wrong ways. These things you have to prime because the holes get plugged up. So you have to prime this. Ha! Well, this one's empty, but you do have to prime it. And then correct technique for using a nasal spray is for a patient to sit up straight, chin down on the chest, block one nostril, nozzle up the nose, and angle it towards the ear, always away from the septum. The septum is more vascular than the other side and will tend to bleed more. So you want to divert the medication away from the septum and over towards the ear. Sometimes it's more ergonomically correct to have them do the opposite side like this. 2 puffs, again, 2 sniffs. Again, it's the same as 2 sprays. It's never choo-choo. It's never like that. It's 1, 1, 2, 2. But the important thing to remember is to have them put the nozzle up their nose and angle it towards the ear. If a patient's using nasal sprays and nasal irrigation, obviously you tell them do the nasal irrigation first and follow with the nasal spray so that the medication has tissue to sit on. The next thing that I want to talk about, you guys, is mucus clearance devices. Now what we have, I don't think we have these anymore, do we? Okay. But we do have these still. Okay. So the acapella mucus clearance device. This incorporates 2 ideas for mucus clearance, well 3 actually. It's an expiratory maneuver. People exhale through this device. There is an aperture, an adjustable aperture inside, which will allow them to increase the resistance if they turn it clockwise, or decrease the resistance. The size of the opening is increased or decreased to increase or decrease the resistance. If they turn it towards the minus sign, counterclockwise, decrease resistance. The third thing is that there's a flow interrupter in here, which acts as a percussive action. So, three things that work here. Expiratory, it's an expiratory maneuver. In exhalation, mucus is naturally directed towards the central airways. The resistance for COPD patients who have dynamic airway collapse, this helps to stent, the resistance helps to stent the airways open so that the mucus can get past what was, where it was being trapped when the patient's airway collapses during exhalation when they're not using this. And the flow interrupter helps to jar the mucus loose from the airways so it can be coughed up. It doesn't matter, people do not have to take a deep breath to use this device. When you think about it, dynamic airway collapse doesn't happen at the beginning of inhalation, it happens at the last third of exhalation. So what you really want them to do is exhale only, the only part that they don't have to take a lungful of air. Exhale to residual volume till they can't exhale anymore. It's that last third of exhalation that stents the airways open, that helps to move the mucus past that obstruction, and the resistance, it helps them to cough this up. There are two types of acapella devices. The blue is the low range resistance for people who aren't quite as strong, and then the green is for high airway resistance, high range. Low range, high range. And this thing is cleanable too. These last ones, they're pretty sturdy. Typically, unless somebody coughs into this device, coughs something into this, they're not going to have to wash this part. But this, warm soapy water, warm clear water, and sit it on the drain board to dry. With any devices that are being cleaned, they should never wipe it down. The reason being that you don't want to put fur balls into the, something that the patient is breathing in, like from a paper towel or a towel. You don't want those little lint pieces. The last thing I want to talk about here is the Aerobica, which is our new mucus clearance device, and we'll be replacing the acapella device. This is the same exact principle, except that instead of having a flow interrupter, it has this cool reed inside, which acts as the percussive device. It flutters back and forth like this. There is a resistance adjustment here. You can increase the resistance here or decrease. There's a plus sign and a minus sign. This is as much resistance as you can get out of it and the least amount of resistance. The principle is the same. Exhale through the device. The flow is outward towards the central airways. The reed flaps back and forth to help jar the mucus loose from the airway, and the resistor helps to stent those airways open so they can cough the mucus up. And that's everything I have for you guys. If you have any questions, give me a call, 45676, or for Reed.
One question regarding to the aero chambers for pediatrics. What's the best way or appropriate way to deliver medication to pediatric patients with aero chamber? Do you count? How do you seal it?
Yeah. So,
And
bear in mind, I'm an adult person, but when you're giving these to kids, you don't want them to inhale and necessarily exhale through it. You want them to inhale. They do tell you to. I hate doing this. It's so mean. Doesn't it seem mean to do this to a little kid? So actuate and put the mask over the mouth. So like this. Now, granted, the kid this side, they're going to be screaming. Good luck. You just do what you can with the little baby. But kids this size are typically, they have some rational thought going on. And I think it's better if you just actuate and then put the mask on the face.
And regarding to steroids, do you tell them to just swallow the water? Or
for little kids, they can
Yes.
swallow it. Good luck, and you can't get little kids to. You just give them a drink of water afterwards.
Okay, thank you so much
My
for
pleasure.
the great presentation, and have a great day.
Thank you.